Hi, Zach. Nice to see you today.
Hi, Ross. Thanks for having me.
Thanks for joining us. We really appreciate you joining the Familywood podcast. You and I go way back. It's nice to connect with you on from going from an academic setting to a professional setting like this, and it's nice to see you, man.
Yeah, likewise.
So I always like to kick things off with just a banter, a discussion about who you are and what your relation to addiction is and recovery is. I know you have a heck of a background clinically and academically. So yeah, would you mind just sharing a little bit about yourself?
Yeah, sure. So I'm a clinical psychologist and a researcher in psychopharmacology. So a lot of my research is looking at, novel applications of potential drugs of misuse. So I work with cannabis as a medicine and psychedelics as a medicine in my research world, but in the clinical world, I spend a lot of time working with people who want to change their substance use. I started probably about 20 years back working at the University of Chicago on trials of naltrexone for people who are struggling with alcohol, with problematic alcohol use. And I was also doing therapy for smoking cessation back then. So that was really my first experience directly working with people who want to change their substance use. And then I really haven't stopped since then. I did my clinical fellowship was at Brown University working with partner violence interventions that focused on alcohol use. So, with domestic violence, so much of it is related to substance use. One of the most effective ways to intervene is to help people stop using substances. Did a bunch of work there, and then when I moved to UBC for my job now, where I'm a professor at UBC, one of my goals was to work in substance use, and I've sort of been embedded in various aspects of the community there. I would say maybe a little over 10 or so years ago, started the problematic substance use clinic at UBC, where we work with adults and youth, brief interventions, more long-term stuff, doing outreach with unhoused individuals. So the whole thing, sort of seeing the whole, I like to think the trajectory. So I've worked with people who are, very affluent. I've worked with people who have very few resources, youth, older adults, mostly alcohol, but also worked with people who are trying to reduce, quit cocaine, stimulants, a little bit of
The
opioids.
whole spectrum, eh?
Yeah, I like to think so. I get my feet wet in a bunch of areas.
Yeah, right on, right on. I know this, the audience may not. You're also a very quirky, fun guy, well known for very amusing and informative. Yes, one of those professors that can hold attention of students. Yeah, I think that's an important thing to spotlight.
Oh, that's good to hear. Thanks for that.
Your uniqueness
I
in
try.
that way, Zach. You do try,
I
and
do
then
try.
the effort
I'm always glad to be
is
invited.
no.
Yeah.
Tell us, if you will, a little bit about your experience working with families in recovery, albeit the person who's struggling with addiction talking about their family challenges, or working with actual loved ones who are impacted by somebody else's addiction.
When you say that, a couple things come to mind. A lot of the time when I'm working with adults, and particularly in some of the early work that I was doing more with partner violence, it was couples. So working with dyads, if some often there's a saying in substance use treatment that often people are there, but because of a nudge, a judge, or a grudge. And so a lot of the time that nudge is coming from a family member. And a lot of the time, part of the path to recovery is not just internal to the person that's struggling, but it's also going to require some contextual changes. On the most basic level, is your partner going to still be using substances around you? And then, it gets even more subtle to that. How are you repairing some of the damage that's been done to the relationship through the problematic substance use? So having a partner in there, if someone has a partner, is a real important piece that I always hope to integrate. And it can be complicated, particularly if there's been violence. But in most cases where there isn't that high level of conflict, it can be really helpful to be able to address the context where people are going back home to, and that has a lot to do with their partner. And of course, when I'm working with youth, a big piece of it is the family of origin. What's going on at home, and so many of the referrals that you get, particularly with youth, are because of family dynamics, family concern. So bringing it back around to the family is an important piece.
Safe to say that you're aligned with the belief that it's a family systems issue as much as it is an individual issue.
It's such an important part is to have, so much of addiction has to do with connection. It has to do with relationships, and the most important relationships are family. So family's got to be a piece of it, 100%.
Yeah, they sure do, don't they? We're aligned on that. Um, so every week on this Familywood podcast, we have a two segments that we do. The first segment is an organization spotlight. So during this segment, we like to take time out and have a discussion about an organization that's directly related to addiction or family support or something in that world. And I know you have a heck of a background with the BC Center on Substance Use, so I thought we could do that this week. I'll open up and would love to hear your experience with the BCCSU. For viewers that may not know, the BCCSU is a leader in advancing evidence-based approaches towards addiction treatment and clinical guidance and research. Their initiatives really important right now, maybe more than ever, related to harm reduction and policy development. What's your role as of today with the BCCSU, Zach?
Yeah, well, I'm an affiliated scientist. I'm part of the team there, particularly working on cannabis policy. And the area that I'm most involved with is looking at some very high risk cohorts. So we look at youth who are using often intravenous drugs or using opioids. There's also following cohorts of folks who are unstably housed and socioeconomically marginalized, a lot of them on the downtown east side. But because of Vancouver, I should say, because your audience is probably broader than BC. So the downtown east side of Vancouver, which is an area with a great concentration of people with a variety of mental health and substance use challenges, and also a place where there's a lot of innovation in terms of how we address those problems. But that's not all the BCCSU does. Is also very involved in developing best practices for opioid agonist treatments and, as you say, harm reduction, and providing supervised injection, safe consumption sites, and harm reduction tools, outreach. There's a lot of things that the BC Center does, and I would say the harm reduction piece is probably the most prominent, but it's it's meant to be BC
Given
wide.
in today's climate.
Yeah, no, it's meant to be BC wide too, though. So we're always looking at ways that it can be, it's a very important center down at the downtown east side, but it doesn't capture the reality of everyone who's using substances. So we also are looking at ways, I think, as we move forward to expand it to other regions of British Columbia, because, even though I think that's the most visible, people will go to Vancouver and they'll say, "Oh my goodness, I was in the downtown east side. What a tragic, scary situation it seems to be down there." We have rates of harm from the drug poisoning crisis in places like Kamloops and Kelowna that are by population size also really bad in terms of the harms. So we're looking at ways that we can translate what we learn.
And not just impacting those who are experiencing homelessness.
Not at all. No, exactly. It's super important to focus on those high risk people, and there's a lot of ways that we can help and a lot of things that we can learn, but it's a mistake to think that that is the sort of modal substance use a modal individual with a substance use problem is not necessarily on the downtown east side. They could be anywhere.
I can't help but think, just related to this, another organization, Moms Stop the Harm,
Yeah.
and a group of parents that have been directly affected by this current crisis that we're in,
Well, it goes back
related
to
to
what you're saying about
overdoses.
families, and that's something that really strikes me working with youth. Is so many of the youth that are struggling with substance use. When you look at their biography and their context, so many of them have siblings or close friends or relatives or uncles who are also have struggled and maybe even lost very close people. The sort of reverberations that come from these tragic events, the overdoses and the deaths, yeah, they echo far beyond the primary victim.
Yeah. So how long have you been? I think you've been a while, but how long have you been with the BCCS?
I think like about 7 years. Yeah,
Seven
pretty
years.
much. It hasn't. It used to be part of the Center for Excellence for HIV/AIDS, and then it split off as the focus became more and more on harm reduction and less on primary. But I mean, the tremendous work that was done in addressing the AIDS crisis, a lot of that really pivotal work came out of UBC. So it's something that we can be proud of here
Cool.
in BC.
I
That,
didn't know that.
oh, yeah,
Fun
yeah.
fact.
A treatment is cure, I think, is one of the things that was recognized, that if you used a bunch of different approaches, people have their viral loads so low that they appear to be no longer symptomatic. So a lot of that primary work and then reduce the spread.
That's coming out of UBC.
Yeah, yeah. Yeah, it's one of the Julio Montana is really the name that it's most closely associated with that. The work that I do there is a lot focused on how people who are problem using opioids in ways that are problematic, unregulated opioids, are trying to use cannabis as a harm reduction tool.
Yeah. And so what if any conversations or initiatives consider the family during your time at the BCCSU?
So a lot of the work that I've done there has been research focused, and biography is important. So we sometimes ask questions about family of origin and try to map out relationships. I think there's more work to be done there, particularly from research. We recognize as clinicians how important it is to work with family and to consider family issues and influences. But when it comes to research, we tend to really focus just on the individual and sometimes at social factors more largely. But I think the family, in many cases, is a piece that's missed. So hopefully more down the road.
Rah, rah, rah. Yeah, you speak my language. And Zach, that's a great segue into our next weekly segment, which is a conversation about a relevant piece of literature, something related to addiction or related to family systems. So this week, I chose an article for us to discuss. It's the 2020 meta-analysis by Aris and Fairbairn in the Journal of Consulting and Clinical Psychology. The study, I'll just kind of give a bit of an overview of the paper and we can banter about it in general. And I'll post a link to the article for those who are watching. They can read it as well. So the 2020 meta-analysis by Aris and Fairbairn asked a simple but important question. When we bring in significant others, partners, parents, or close family members, does it actually improve treatment outcomes for substance use disorders compared to treating the individual alone? The article went on to talk about some of the methods, which were analyzing 16 randomized controlled trials at 2,100 participants. The trials compared significant other involved treatment, like behavioral couples therapy or a multi-dimensional family therapy, with established very traditional individualistic approaches such as CBT or motivational enhancement or 12-step facilitation. The results from the article were, I think, impressive. That's my interpretation. They showed a small but consistent advantage for involving significant others with an effect size Cohen's d of 0.24. In particular, in practical terms, that equals roughly 21 fewer days of substance use per year. So the individuals who had family involved in their treatment had 21 fewer days of substance use per year. Importantly, too, that the benefits were long-lasting, and they persisted following the assessments for up to 18 months. So less drinking or less consuming, and the effect lasted a long time. The takeaway is clear. Recovery, or from this article, the takeaway is clear that recovery doesn't happen in isolation. Systemically engaging family members provides a measurable and durable boost to treatment outcomes. I chose that one. I'm always a fan of meta-analyses because they seem to be more. All right.
No, you're right.
So hearing that, what are your thoughts, Zach?
Well, it's not surprising, and I think I would go as far as to say it's a best practice when it's possible. You want to be.
So you're saying it's best practice to involve the family
bring in
treatment?
another, yeah, absolutely, because
Yeah.
and not always, because sometimes family of origin can be part of the still be using, and maybe there's conflict there and maybe it interferes. But that's a real minority of cases. In most cases, the presenting client has someone in their life who is supportive and who wants to know more. And I think a side piece of it that we sometimes don't think about, particularly if it's couples, is that there may be, suspicion, concern around what's going on. What's going on with your therapy? What are these changes you're making, and who are you talking to about it?
That's so at Familywood, we work with the spouses, parents, and adult children of those who are entering recovery. Oftentimes, the person with addiction is in treatment, and there's a fair amount of psychoeducation about what is actually going on for that person. It also provides a heck of a therapeutic opportunity, so to speak, to explore like what's going on for them to want to know so much about this person's treatment and potentially consider what kind of control they're struggling to let go of.
And often, as much as a partner wants to see that change and very sincerely wants to see that change, they've also accommodated over the years to the pattern of substance use. So any change can be disruptive, even if it's a change for the positive. So the more you can bring in the partner and prepare them to accept the change and work with it to maximize it, and articulate concerns they might have about it, that can be really empowering. So I think it really increases the chances for success if, when someone is transitioning out of treatment back home, the home environment is aware of what happened in treatment, so that you don't have the right hand and the left hand doing different things.
Yeah. I also, like, on that note, and anecdotally, know quite a few people who work in treatment centers and often talk about the load on their cases from family members seeking information about the treatment and what's going on with their loved one,
Yeah,
and how it becomes oftentimes reported as a bit of a distraction from their mandate, which is the individual with addiction.
sure. And I think that's part of why we need to
We'll
switch,
come back to the article, but you
right, is
when
to help
you
help
said
the provider.
audio, good old technical issues, eh, Zach?
Yeah, I think
You
we're
were
having a
talking about
little bit of
the
a
spouse being comfortable. I couldn't help but think about, gosh, have you seen the movie When a Man Loves a Woman?
I have not.
It's a good one. Vulnerably good watch for anyone who's watching this podcast and wants to see under the hood of a family experiencing addiction, and a husband or a wife, but in this case it's a husband who's struggling to let go of what they were comfortable with, which was their spouse who was in addiction and broken, for lack of a better term.
Yeah,
Um,
interesting. It's more complex than you sometimes
some
think. It's not always the person that's getting the treatment that is, they're the identified patient, but often there's stuff in the relationship. Often there's stuff with a partner back home where they may be the ones that are showing up for treatment, but there's room for change in the broader context that can be welcomed.
Yeah. And so what kind of family involvement or treatment do you think may be effective from your experience?
I think it varies really depending on a lot on the context. We've talked a lot about couples and the idea that one person is in treatment and the other person is sort of waiting it out at home, hoping that there's going to be a change. And in those cases, I think, I think starting with, it looks like I'm having some internet problems. Maybe we'll just wait a second for it to catch up.
I think we've lost you there, Zach.
It says trying to reconnect, but it looks like it sees me. Do you hear me, Ross?
I think we've lost Zach. Well, hey, that's just the way the internet goes. Yeah, it is what it is. I'll give him a minute to see if he hops back on, right?
Okay, I should be back. Am I back?
Hey, he's
Hey.
back. Look
I
who's
don't know
back.
why. Always
Back
the
in.
worst times, right? So
Yeah,
anyway, so I think what we were talking about, and,
technology.
and of course we can edit it, so it's not the end of the world, right?
It's all good.
What kind of involvement is optimal? I think in couples, and again, it varies very much from case to case, but if I were to generalize, I think first you want to hear from the client and establish that safety, determine how it might be best. I always like to let the client lead, but I'll explore, is there someone who we could bring in? When do you think we could bring them in? What might be the benefit of that? But, the short answer is bring someone in early, not the first couple sessions, but early on in the progress, and then maybe see if they can come back later, somewhere near the end. I'm sort of have a CBT orientation in terms of the idea that the therapy should be a specific length of time. You can extend it if you need be, but I think we want to have an end in sight pretty soon after we start. So, with that in mind, if you know what the parameters of the treatment are going to be, then you can start to say, okay, bring in a partner quarter of the way through, and then again near the end, something like that, just to make sure, first of all, to make sure that there's alignment on the goals and to demystify the process. And then later on in the end, for a warm handshake and an opportunity to ask questions and to test out some of the ideas around follow-up, and also a chance for the patient to demonstrate the changes they've made, because that can be really powerful. One of the things that takes a hit when people go into substance use treatment can be their sense of self-esteem and self-efficacy. So being able to show to their partner.
And it takes a while. I often work with the family members and work on patients because it takes a while for them to rebuild that trust. They have to see those changes maybe 3, 4, 5 times in order to actually believe them.
Understandably. So giving an opportunity for that and giving an opportunity to voice that. I've had you bring in the partner sometimes, and they'll say, "Yeah, I don't buy it. I don't." And it's almost like there's an alliance between the therapist and the patient, and then the partner is sort of playing the skeptic, and that's fine. If that's the perspective, then it's best to give that a chance to come into the light than to keep it, underground and sort of snippy comments and demoralizing attitudes. Let's talk about it. Let's talk about the trust that's been injured. Let's talk about what it would take to repair it. What would recovery look like for you as the partner, not necessarily as the patient, and how do we negotiate those different visions of recovery?
So Familywood, we work with the clients,
In the
the spouses, the parents,
Yeah.
with their own individual treatment plan. So the individual with addiction has their own individual plan. The parent or the spouse has their own plan, and we work on the things that they're going through. I kind of think of it like a bit of a Venn diagram. There's some work to be done together.
Mhm.
There's some work to be done individually on each. What are your thoughts on this as a practice for the family to have their own kind of treatment plan as well?
I think that can be huge depending on, again, depending on the family can mean a lot of things. If it's
Context.
parents of children, I think there's often some very real trauma, some guilt that they need to go through, that they need to, at least there's so much shame and stigma that goes with being a parent to someone who struggles with addiction. There's so much shame, and that's not helpful. So not just saying, "Oh, it's
It's
not your
such a
fault."
frequent report for the parent to feel responsible for the child's addiction and be living with haunting guilt.
Yes, so, and that doesn't help them be part of the recovery. So, if that guilt worked and made people better, then we'd consider it. But I've never seen that. I always think, when we're talking about problematic substance use, there's never a deficit in shame and guilt and disappointment. So we don't need more opportunities to amplify that. It's there. What we want to say is, how can we build moving forward? And that building is going to involve the family. It's going to involve the whole system most of the time.
Yeah, cool. Good discussion, Zach. Um, uh, as we kind of wrap up here, really want to sincerely thank you for your time and for joining us and for sharing your wisdom. One of the wiser guys in the field out there, and yeah, just really appreciate you taking the time to share with the audience some of your perspectives and the journey that you've had.
Well, it's important work you're doing, Ross. I'm just glad that you stay in touch and count on me anytime. I'd be glad to be back anytime. It's been a pleasure.
Thanks. Enjoy the afternoon and take care, Zach. See you,
Take
buddy.
care. Bye.
Let's just hold on now. Wait 1 minute before you close up.